The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/ZVF860. Downloadable infographics are also available.
Hello, I'm Dr. Edward Fox from Central Texas Neurology Consultants and the University of Texas Dell Medical School. Welcome to this educational activity entitled A Visual Guide to B-Cell Therapies in Relapsing MS, clarifying the options in an expanding treatment landscape. Let's begin with a visual exploration of MS pathogenesis and the mechanisms of action of anti-CD20 monoclonal antibodies. Most individuals, estimated at 85 to 90%, have relapsing remitting MS at diagnosis with relapsing remitting neurological deficits. RRMS often evolves to secondary progressive MS, a state of worsening disability without obvious remission. About 10% to 15% of patients present with primary progressive MS, with gradual worsening from the onset. MS is primarily an immunologically mediated disease thought to reflect the impact of environmental exposure on genetically susceptible individuals. In RRMS, relapses and new MRI lesions are closely related. Primary progressive disease is associated with a more gradual onset of symptoms. In looking at the history of the disease-modifying treatments, the initial focus was on T cells. It was thought to be mediated by autoreactive T cells based on data from animal models, such as EAE, and an association of HLA alleles related to T cell activation. There was also genome-wide association studies that observed immune alterations in people with MS. It was thought to be a consequence of an imbalance between the Th1 and Th17 pro-inflammatory activity versus the T-regulatory anti-inflammatory activity. Interactions between macrophages and T cells were considered to play central roles. The emerging view of disease-modifying therapies has focused on a shift to the B cells as well. The key role of B cells in MS pathophysiology was highlighted by the anti-inflammatory effects of rituximab, monoclonal antibody targeting the B cell marker CD20 in relapsing remitting MS. Other indications of a potential role for B cells in MS pathophysiology include the presence of B cells and plasma cells with hypermutated immunoglobulins in MS lesions. The peripheral and central interactions that drive MS pathophysiology include systemic peripheral events contributing to the relapsing remitting disease that lead to aberrant immune cell activation, trafficking to the central nervous system, and reactivation within the CNS. Maturation of the B cell response also seems to occur peripherally in the cervical lymph nodes, which may explain why the systemic B-cell depletion is effective. Abnormalities in B-cell peripheral tolerance, which are mediated by T-regulatory cells, appear to contribute to MS. It has been hypothesized that CNS compartmentalized inflammation contributes to progressive multiple sclerosis. The potential B-cell roles of MS pathophysiology include autoantibody production. The role of these autoantibodies in MS pathophysiology is unclear. Oligoclonal bands are a hallmark of MS and signal abnormal intrathecal B-cell antibody production. Antibodies making up oligoclonal bands are not thought to cause CNS injury, though, because they primarily recognize ubiquitous intracellular proteins, which suggests a response to debris from dead cells rather than a primary role in injury. However, a subset of patients, about 30%, have circulating antibodies with in vitro complement-dependent demyelinating activity, suggesting some patients with MS may have circulating pathogenic antibodies. Potential B-cell roles in MS pathophysiology also includes antigen presentation and T-cell activation. B-cells are highly effective antigen-presenting cells. They express linear epitopes in the context of MHC. They can also present three-dimensional epitopes bound to cell surface B-cell receptors. B-cells that are activated by antigen to T-cells become antigen-presenting cells that can promote immune responses. An additional potential B-cell role is cytokine production. In patients with MS, B-cell cytokine production is skewed to favor inflammation. Production of pro-inflammatory cytokines is elevated, and these cytokines contribute to activation of pro-inflammatory T helper cells. Regulatory B cells can also produce anti-inflammatory cytokines, but this response appears to be deficient in patients with MS. The pathogenic effects of B cells in MS include actions within the central nervous system. B cells that have migrated to the CNS can infiltrate the brain parenchyma in patients with MS. B cells in the CNS that receive appropriate help from T cells can proliferate, aggregate, promote meningeal inflammation, and associate with other cells to form lymphoid follicle-like structures. These structures have been observed in relapsing MS, secondary progressive MS, and active primary progressive MS, and are often associated with a more severe MS course. CD20 is a transmembrane ion channel, thought to participate in calcium release from intracellular stores during B-cell activation through the B-cell receptor. It is expressed in a wide range of stages along the B-cell lineage, and anti-CD20 antibodies result in depletion of B-cells expressing CD20. Different anti-CD20 monoclonal antibodies bind to different CD20 epitopes, so we can distinguish these four products based on which area of the CD20 molecule is bound. The regimen for these products is different as well, as is the immunogenicity of the products. The immunogenicity of the products is based on whether they are chimeric, humanized, or recombinant, in that there is a greater likelihood of the formation of antibodies to chimeric antibodies. The effector mechanisms for anti-CD20 monoclonal antibodies in MS is different between ocrelizumab, ofetumamab, rituximab, and ublituximab. Complement-dependent cytotoxicity and antibody-dependent cytotoxicity is present for all four, but ublituximab is much more dependent on the antibody cytotoxicity, whereas ofetumamab is more dependent on complement-mediated cytotoxicity. So let's now delve a little bit deeper into the mechanisms of action of anti-CD20 monoclonal antibodies in the treatment of MS.
Anti-CD20 monoclonal antibodies target B-cell populations that express the CD20 molecule on the cell surface. In the treatment of MS, there are four anti-CD20 monoclonal antibodies with distinct structural and CD20 binding characteristics. These antibodies include rituximab, a chimeric IgG1 antibody, ocrelizumab, a humanized IgG1 antibody, ofetumamab, a fully human IgG1 antibody, and ublituximab, a chimeric glycoengineered IgG1 antibody. Ocrelizumab and rituximab bind to overlapping epitopes in the large loop of the CD20 molecule. Ofetumamab binds to a unique epitope in the large loop and an epitope in the small loop. And ublituximab binds to two non-overlapping epitopes in the large loop. When anti-CD20 monoclonal antibodies bind to CD20 on the surface of B cells, they activate two mechanisms that result in B-cell destruction: antibody-dependent cellular cytotoxicity, or ADCC, and complement-dependent cytotoxicity, or CDC. ADCC occurs when Fc receptors on effector cells, such as natural killer cells or macrophages, bind the Fc region of the anti-CD20 antibodies that are attached to targeted B cells, leading to the release of cytotoxic factors that cause the death of the targeted cell. ADCC is the primary effector mechanism of ocrelizumab and ublituximab. CDC is initiated by the binding of the complement protein C1q to the Fc region of anti-CD20 antibodies that are bound to targeted B cells. This initiates the activation of the complement cascade and leads to the formation of the membrane attack complex on the cell surface, causing pores to develop on the cell surface that disrupt the cellular membrane, resulting in B-cell death. Both rituximab and ofetumamab mediate their effects mainly through CDC.
So, in our second part, let's take a guided tour of the clinical evidence for managing relapsing MS with anti-CD20 antibodies. In discussing the clinical trials of anti-CD20 antibodies in treatment of multiple sclerosis, we will start with rituximab. Rituximab is a chimeric mouse-human IgG1 approved for the treatment of B-cell lymphomas since 1997. It is used off-label in multiple sclerosis. The Hermes trial was a randomized, double-blinded, placebo-controlled, multi-center phase 2 clinical trial evaluating the efficacy and safety of rituximab in relapsing remitting multiple sclerosis patients over 48 weeks. It was administered intravenously every 24 weeks during the course of this trial. Rituximab significantly reduced gadolinium-enhancing lesions and relapses versus placebo. In 2017, ocrelizumab became the first anti-CD20 monoclonal antibody approved for treatment of MS and is the only approved therapy for primary progressive MS. The approval for the relapsing MS indication was based on the results of two identical phase 3 trials that were conducted to test the efficacy of ocrelizumab versus beta interferon in relapsing MS patients over 96 weeks. These studies included a total of over 1,500 patients with an EDSS score between 0 and 5.5 who had suffered 2 or more clinical relapses in the 2 years prior to the study, or at least one in the past year. In looking at the key clinical and MRI results of the OPERA trials, both studies showed a significant decrease in the annualized relapse rate for patients treated with ocrelizumab at 96 weeks than those treated with beta interferon 1A. The percentage of patients with progression in their disability was lower at both 12 and 24 weeks. There was also a 94% decrease in gadolinium-enhancing lesions with ocrelizumab compared with beta-1A interferon in both trials. The mean new or newly expanding lesions on T2-weighted MRI imaging was also significantly lower in the group given ocrelizumab versus the interferon beta-1A group in both trials. For the ocrelizumab open-label extension study design, patients that were initially randomized to ocrelizumab were continued on ocrelizumab, whereas patients that were randomized to beta-1A interferon were transitioned to ocrelizumab given every 6 months. Over a period of a number of years, these patients have been followed both clinically and radiographically for ongoing disease activity. The results of the open-label extension trial show that those patients that were initially randomized to beta-1A interferon had a very rapid decrease in their annualized relapse rate as well. The low level of annualized relapse rate was maintained in both groups for a period of up to 4.5 years of open-label extension. Over 6.5 years of the double-blind plus open-label extension, the risk of reaching 48-week confirmed disability progression and the risk of requiring a walking aid were both significantly lower in those who initiated ocrelizumab earlier versus those who switched from interferon to ocrelizumab for the open-label extension. Neurofilament light chain is a biomarker of neuroaxonal injury in multiple sclerosis. Data from the OPERA studies that was presented at the ACTRIMS and ECTRIMS 2020 virtual meeting showed that ocrelizumab significantly reduced NFL levels in patients with relapsing MS compared to interferon in patients with and without disease activity. The relationship between NFL and ocrelizumab treatment versus interferon treatment on brain atrophy was also examined. Ocrelizumab was found to reduce brain atrophy in patients with high and low baseline neurofilament light levels, better than interferon in patients with relapsing MS. Ocrelizumab's dosage and administration begins as a 300 milligram infusion, followed by a second 300 milligram infusion after 2 weeks, and thereafter every 6 months, 600 milligrams being infused. Prior to ocrelizumab dosing, patients are required to be pre-medicated at least 30 to 60 minutes prior with 100 milligrams of methylprednisolone or an equivalent and an antihistamine in order to avoid infusion-related reactions. Patients are required to be observed for at least 60 minutes following ocrelizumab infusion. The Ensemble Plus study was a randomized, double-blind study that investigated the tolerability of 600 milligram ocrelizumab when administered over a shorter infusion time of 2 hours rather than 3.5 hours. The majority of infusion-related reactions were mild or moderate in both groups, and there were no IRRs that were serious, life-threatening, or fatal, and no IRR-related discontinuations occurred. Therefore, in December 2020, the FDA approved the shorter 2-hour infusion time for ocrelizumab, dosed twice yearly for patients with relapsing or primary progressive MS. Ofetumamab is a third-generation, fully human immunoglobulin G1 kappa monoclonal antibody that was approved for use in August 2020 for the treatment of relapsing forms of multiple sclerosis, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. The approval was based on the results of the Phase 3 Asclepios 1 and 2 trials, which were conducted to test the efficacy of ofetumamab versus teriflunomide in relapsing remitting MS patients over 30 months. These two trials included over 1,500 patients with active relapsing MS, with EDSS scores of 0 to 5.5 at screening, who experienced one or more relapses in the past year or two or more relapses in the past 2 years, or had a positive gadolinium-enhancing MRI lesion noted in the year before randomization. At the end of the trials, patients receiving ofetumamab had significantly lower annualized relapse rates than the patients receiving teriflunomide. Pooled analysis showed significant reductions in 3-month and 6-month confirmed disability worsening with ofetumamab versus teriflunomide. Treatment with ofetumamab was associated with a 95% decrease in the number of gadolinium-enhancing T1 brain lesions and significant reductions in the number of new or enlarging T2 lesions on brain MRI. There was also a significant decline in the levels of serum neurofilament light chain in the ofetumamab-treated patients compared with the teriflunomide-treated patients beginning at month 3 and reaching 23 to 24% difference during the course of the trial. Outcomes data for the subgroup of 615 newly diagnosed treatment-naive patients who received ofetumamab or teriflunomide as a first-line therapy in Asclepios 1 and 2 trials were presented at the ECTRIMS Virtual 2020 meeting. Ofetumamab showed superior efficacy versus teriflunomide in this subgroup of patients with low absolute relapse rates, low MRI lesion activity, and longer time to disability worsening, consistent with the overall study population. So in another presentation, prognostic value of baseline serum neurofilament light chain levels for on-study disease activity and worsening in patients with relapsing MS was evaluated in the Asclepios 1 and 2 studies. Patients were stratified by median baseline serum NFL levels, and outcomes were examined in all patients and in subgroups of newly diagnosed treatment-naive patients. Results indicated that patients with high serum NFL levels at baseline developed more new or enlarging T2 lesions per year on study than patients with low serum NFL levels, and the prognostic value of baseline serum NFL levels persists for 2 years. In looking at the baseline serum NFL levels, predicting the brain volume loss per year, what was seen is that patients with high baseline serum NFL levels also had higher annualized rate of brain volume loss than patients with low serum NFL levels. The results were consistent in the subgroup of newly diagnosed and treatment-naive patients. However, patients on ofetumamab experienced greater reductions in MS disease indicators, including clinical and MRI measures, compared to patients on teriflunomide across all levels of baseline serum NFL. Ofetumamab is the first Bcell therapy that can be self-administered once monthly at home via a subcutaneous injection with a pre-filled auto-injector pen or syringe. The recommended dose is 20 milligrams by subcutaneous injection at weeks 0, 1, and 2, followed by subsequent dosing of 20 milligrams subcutaneously once monthly, starting at week 4. If an injection of ofetumamab is missed, it can be administered as soon as possible without waiting until the next scheduled dose. Subsequent doses can then be administered at the recommended intervals. Ublituximab is a novel chimeric immunoglobulin G1 anti-CD20 monoclonal antibody that has been glyco-engineered to enhance affinity for all variants of the receptors, thereby producing a potent antibody-dependent cellular cytotoxicity. Ublituximab targets a unique epitope of CD20 not targeted by the other CD20 antibodies, and it's demonstrated 100 times greater NK cell-mediated ADCC in vitro than rituximab. A Phase 2 48-week placebo-controlled multi-center trial was conducted to determine whether the enhanced ADCC potency of ublituximab can benefit patients with relapsing MS at lower doses than those used in oncology, and whether it can be tolerably administered in a more rapid infusion time than those of the other anti-CD20 infused monoclonal antibody therapies. All patients received 3 IV ublituximab infusions administered on days 1, 15, and a week 24 that varied the dosage between 150 milligrams and 600 milligrams and the infusion speed between 1 to 4 hours. Ublituximab led to more than 95% peripheral CD19 positive B-cell depletion in all treated patients within 24 hours of receiving the first 150 milligram dosage, and it was maintained throughout the entirety of the trial. Ublituximab showed promising efficacy, with 3/4 of all ublituximab-treated patients showing no evidence of clinical or MRI disease activity during the 48-week treatment period. Furthermore, there were no new or persisting T1 gadolinium-enhancing lesions detected on brain MRI in any ublituximab-treated patient at week 24 or week 48, and the mean relapse rate was reduced by 95% from baseline, with 93% of patients remaining relapse-free on study. Moreover, 92% of patients had no 24-week confirmed disability progression, including 17% of patients who showed confirmed improvement in EDSS scores. Ultimate 1 and 2 are 2 independent phase 3 double-blinded multi-center studies evaluating the efficacy and safety and tolerability of ublituximab versus teriflunomide in subjects with relapsing forms of MS. Ublituximab is administered in these trials as 450 milligram 1-hour IV infusions every 6 months, following a day 1 infusion of 150 milligrams over 4 hours and a day 15 infusion of 450 milligrams over 1 hour. The Ultimate 1 and 2 trials enrolled over 1,000 patients with relapsing MS across 10 countries. In December 2020, positive top-line results were reported. Both studies were reported to have met their primary endpoint, with ublituximab treatment demonstrating a statistically significant reduction in annualized relapse rate over 96 weeks when compared to teriflunomide. In discussing the safety of the anti-CD20 antibodies, prior to the therapy administration, screening for chronic or active infections such as hepatitis B and C, HIV, varicella, and measles may need to be done. If another medication is being used for the treatment of multiple sclerosis prior to anti-CD20s being administered, consideration will have to be given as to whether a washout period will be necessary. During treatment, patients on anti-CD20 antibodies will have to be monitored further for safety as well as efficacy to determine whether ongoing treatment will be possible. Current recommendations contraindicate anti-CD20 therapy during pregnancy and emphasize the use of contraception during therapy. Currently, it is recommended to start pregnancy not earlier than 6 to 12 months after the last infusion. Infusion reactions with anti-CD20 antibodies include infusion reactions that occur within the initial 24 hours following administration. These can occur commonly, and there are usually mild to moderate reactions following the first cycle, with the proportion decreasing through the second cycle and beyond. The most clinically important adverse events associated with anti-CD20 antibodies are infections secondary to immunosuppression. Post-marketing surveillance is looking for any potential association between hypogammaglobulinemia and an increasing risk of serious infections. The most common infections seen with anti-CD20 therapy include urinary tract infections, sinusitis, herpes zoster exacerbations, and upper respiratory infections, as well as reactivation of latent hepatitis B infection. MS patients on anti-CD20 antibody therapy should undergo cancer screening prior to the initiation of the treatment and should undergo ongoing monitoring for cancer as per standard of care. Although there are no cases of PML reported during the clinical trials of the anti-CD20 antibodies for the treatment of multiple sclerosis, there is an ongoing process for monitoring of patients and reporting of PML or opportunistic infections post-marketing. While humoral responses to vaccines are attenuated in patients on anti-CD20 antibodies, use of standard non-live vaccines remains a consideration because a potentially protective humoral response can still be expected. Administration of all immunizations according to immunization guidelines should be done at least 4 weeks prior to initiation of anti-CD20 therapies for live or live attenuated vaccines, and whenever possible, at least 2 weeks prior to initiation of anti-CD20 therapies for inactivated vaccines. There are a number of clinical challenges that we face associated with disease-modifying therapy selection in patients with multiple sclerosis. The multitude of available and emerging DMTs has made treatment selection increasingly complex. Treatment selection must be personalized and based on many patient and disease-specific factors. Careful consideration of the benefits and risks of individual therapies must occur. We have a number of factors that we can use to make these decisions, which include the level of disease activity, as well as individual factors for the patient, which may favor one treatment over the other. As a goal, we should assume that a shared decision-making process should occur with each patient. This takes time and potentially multiple visits with a patient, but what we need is the goals to get initiation of an adequate therapy as quickly as possible while understanding the patient's priorities and concerns about quality of life on each of the medications. We also have to be willing to readdress this on subsequent visits so that our goals are clearly stated, not only at the onset, but in an ongoing manner, so the patient feels that this decision-making has been jointly attained and that ongoing therapy is achieving their goals as well as ours. In the shared decision-making conversation with patients, we now discuss high-efficacy therapies for multiple sclerosis, which definitely includes the anti-CD20 antibody class, because we now have head-to-head data showing superiority of these medications against other FDA-approved medications, including beta interferon and teriflunomide. I thank you very much for your participation and for your attention in today's program.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZVF860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity is accredited by Penn State College of Medicine. This activity is developed in collaboration with our educational partner, PVI, Peerview Institute for Medical Education.